where you're tuning in from. So I'm actually calling in from Philadelphia.
My name is Anna. I am the moderator for this event, and I am in Louisville, Kentucky. And I'm saying that for the first time since I just moved here. We have Dave, our audio producer. He is in San Diego. Is that right, Dave? Great. And our guest expert you'll hear from soon.
Yeah, I'm in Washington, D.C.
DC, great. All right, so we have Alexis from Long Island. Hi, Alexis. Abigail from Michigan. Kelly Simpson from Boston. Hi, Kelly. We have Lauren from Boston as well. Scott and Eliza from Melrose, Massachusetts. Oh, Dave's from Del Mar. Sorry, Dave. Carolina from Arlington. Essence Brown from New York. Hi, Essence. We have, I hope I'm pronouncing this right, Shiab from Long Island, New York.
Yes, Shihab.
Great. Oh, cool. Kelly grew up near Louisville. Angelina from Scranton, Pennsylvania. I used to be from Pennsylvania. We have Aman from Long Island, New York. A lot of people from Long Island. Rachel is also from Long Island. Jennifer from Salem. Neil from San Diego. Lexi, Mount Pleasant, Pennsylvania. Christina from Boston. Jennifer, also from Boston. Bill and Carol Fisher, Collingwood, New Jersey. Welcome, everyone. So great to have you. And we also have some people tuning in from YouTube. So if you're on YouTube watching this, feel free to also type your name and location into the chat on the right.
And for those who just, oh, I'm sorry, I was just going to repeat what Anna said. Yes, we'll just get started in just a minute. But as Anna said, feel free to put your name and location in the chat bar. And also feel free to turn on your video.
Yes.
Usually our events are live and in person and we all get to see each other. So we're going to pretend that we can all see each other and welcome you to turn on your videos. Hey, Adrian. It's great to see you.
I think I remember Daniel from our oil event. You did ask a question then. Good to see you again. A couple more people joined. Adrian from Holyoke, Massachusetts. We have Sarah Grossman from Toronto. Oh, but oh yeah, American living in Canada.
All right, so should we get started?
Let's do it.
All right, I'm sure more people will be joining over the next few minutes, but in the meantime, I'm gonna share my screen so we can get started. Is that showing up okay for you? All right, great. So hi, everybody. I'm Lar Hesse Fisher. I'm the founder and director of Civic Series. If you are new to Civic Series, then I'd like to share that we are a volunteer-led nonprofit organization that helps you understand, think for yourself, and have meaningful conversations about the most important issues of our time. And our events, like this one, allow you to ask questions of experts in a nonpartisan and safe space. So the goal of today's event is to help us all understand the fundamental disagreements that drive the healthcare debate in the US and to answer your questions about it. But before I begin, I just would like to thank our donors, our major donors, the Rhyme and Reason Fund of the Boston Foundation, Amy and Dan Harris, and Ross and Jane Kepner. We are a volunteer-led organization, and your donations go really far in helping us produce content like this. We also want to thank those who've donated to us on Venmo and Eventbrite. If you'd like to give a donation, you can find us at Civic Series on PayPal or Venmo, or you can visit civicseries.org/donate for how you can play a really big role in helping us reach more people. Okay, so here's how tonight is going to go. For the first 20 minutes or so, we'll have a presentation from our guest expert, Dr. Matthew Fiedler. He'll give an overview of tonight's topic, and then we're going to open up for your questions for the last, it says 40 to 30 minutes, so that's a creative way of saying that, for 30 to 40 minutes after that. And then we're going to go into breakout rooms for about 10 minutes. You'll be randomly assigned to a breakout room, and we have a couple of discussion prompts for you. So at 8 o'clock, we'll do that for about 10 minutes, and then we'll come back together and finish answering your questions before we end the event at 8:30. So all of our in-person events are pretty interactive, and we're going to replicate that here. So I'm going to turn it over to our moderator, Anna, who we've already met, who's going to explain how the Q&A part will work for those who are new to Civic Series.
Great. Yeah, hi everyone. If I haven't introduced myself yet, my name is Anna Tran, and I'll be just monitoring the questions that come in. So throughout the event, if you have any questions that you'd like to ask, so the default is that everyone is muted. So when the Q&A time comes, I'll be asking you to unmute your audio so you can ask your questions live. But before you ask your questions, just send it in the chat. It's a public chat so everyone can see it, but then I will just directly message you to make sure you'd like to ask your question live. If not, you can always default and I will ask your question for you. But if you have a question, send it in the chat and then I will let you know when it's your turn to ask your question. So if you have a question, send in the chat or write it down. And if you're watching on YouTube, you can send your question in the YouTube chat. And you can also text your question to a phone number that I will put in the YouTube chat as well. And also put that phone number in the Zoom call as well. And once the breakout rooms come, I'll be randomly assigning it, just like Laura's saying. You'll have 10 minutes and we'll go from there. So back to you, Laura.
Great, thanks, Anna. And again, just want to say for those who just joined, welcome you to turn your video on so we can see you. And I want to emphasize, as I always do at Civic Series events, is that there is no such thing as a dumb question. The point of Civic Series is for you to ask the questions that you fear are too dumb to ask anywhere else. And I will volunteer to be the dumbest person in the Zoom room. So feel free to ask away. Okay, I am very pleased to introduce our guest expert today. Dr. Matthew Fiedler is a fellow with the USC Brookings Schaefer Initiative for Health Policy. His research examines a range of topics in healthcare economics and healthcare policy. Dr. Fiedler, we're so pleased to have you join us today.
Thanks very much for having me. I'm looking forward to the conversation.
Is there anything else that you want to add before we jump in?
No, I think I'll share my screen here. I've got a few slides that may help sort of structure the conversation here, and then get started.
Great, let's go for it.
All right. So thanks again for having me. My goal is I'm going to sort of start with an overview of two big sort of broad topics in healthcare policy that, at least before COVID, were the sort of the focus of many of our national debates about healthcare. I'm going to start with what wonks like me often refer to as coverage policy. So this is, policies encompassing affecting who has health insurance, who pays for health insurance, what that health insurance does or does not cover, and so on. Fundamentally, coverage policy debates are about who should be responsible for paying for healthcare in the United States and what the government's role in that should be. And then I'm going to switch to talking a little bit about policies aimed at changing the overall amount we spend on healthcare. So less about who's paying for it, what's the patient's responsibility versus the government's or the insurance company's responsibility, how much we're spending overall, and what's the role of government policy in making sure that we're spending the right amount on healthcare, whatever we may think that amount is. So as I think we'll see in of course, the presentation and the conversation, those two distinct policy areas, sort of coverage policy and spending policy, often end up pretty intertwined. But I think the conceptual distinction can be kind of useful in practice. So I'm going to start with coverage policy. So just to sort of start things off, I think it's useful to have a quick overview of the current system. So the system looks very different for people under 65 versus people age 65 and older. So if we look at people age 65 and older, almost everyone is covered through a federal program called Medicare. There are a few people who have other sorts of coverage. Mostly it's people who haven't retired yet and are still primarily covered through their employer, but most people are covered through Medicare. If we go to the under 65 population, it's a lot more complicated. So the majority of people are covered through health insurance, through a private health insurance plan they get through an employer. The reason employer coverage is so dominant in the United States is that our tax code, or at least one of the reasons, is that our tax code creates very strong incentives for employers to provide health insurance as a benefit. So if your employer gives you $1 in the form of wages, then you're going to pay payroll and income tax on that dollar. But if they spend $1 on your health insurance plan, then that's not subject to income and payroll taxes. So rather than getting the sort of 65 cents on the dollar you might get of wages, you can get a sort of full dollar of healthcare. And so that creates a very strong incentive for many people to get their healthcare through their employer. There's then another slice of the population that gets coverage through the individual market. They buy it directly from an insurance company, not through an employer. This is one part of the healthcare system that was fairly substantially affected by the Affordable Care Act, which is sometimes also called Obamacare, which was passed in 2010. What the ACA did to this market is it provided subsidies for low and moderate income people to help them afford premiums on the market and to cover some of the cost sharing they might face, so their copays and deductibles and so on, so forth. The ACA also changed how insurance plans in this market are regulated. It said that insurers couldn't charge people different premiums based on their health status. It said they couldn't turn people down based on their health status. And it said that all insurance plans in the individual market had to provide a certain basic level of benefits.
Hey, Matt, can I introduce you? Can I interrupt you? I want to make sure I understand. So you were saying that with the ACA, Obamacare, Affordable Care Act, the two things that it provided for folks who were participating in the individual market, you said first was it helped them get lower cost access to healthcare, right? So what they were paying monthly, the premiums they're paying monthly were less than what they would find otherwise.
That's right. That's right. So it created a tax credit basically that people who buy coverage on the individual market and have an income in a certain range can get, that then reduces the cost of the premiums they pay each month.
Okay, got it. And then the second thing is it actually put regulation on healthcare insurers so that people could get access who might not normally have had access before because they had pre-existing conditions or something else going on.
Right, that's right. And then it also put certain limits on what these plans had to cover. So for example, many plans that were being offered in this market before didn't cover prescription drugs. So one of the things the ACA did is said all the plans that are offered in the individual market, they have to cover prescription drugs. They have to cover what are called these 10 essential health benefits, which are sort of the list of things you would sort of think about as health insurance plans covering: hospital care, physician care, drugs, and so on and so forth.
Okay, it sounds like we could probably spend the whole hour talking about what the ACA covers and doesn't cover. So maybe we'll stop there and we can incorporate more of that later if we have time.
Yeah. So then the next big chunk for this under 65 population is people covered through Medicaid or the Children's Health Insurance Program. So these are programs that are jointly operated by the state and federal government. The federal government picks up most of the money, but states have most of the sort of day-to-day operational control over how these programs run. These programs are available to people with low and moderate incomes and people with disabilities. This is another part of the healthcare system that was changed by the Affordable Care Act. it gave states the option to cover more poor and non-poor people through Medicaid. And it said that the federal government would pick up most of the cost of doing that. So that was the sort of other big coverage policy change in the ACA. There's then a small slice of people under 65 who are also covered on under Medicare because they have a disability. And then there's about 12% of the population that's under 65 that's uninsured. So they don't have coverage from any source. And if they need healthcare, they're going to need to pay for that care entirely out of their own pockets. So with that sort of landscape set up, I'm going to talk in a moment about the sort of broad categories of reform proposals that people put forward in relation to coverage policy. But before I get there, I want to talk a little bit about why people disagree about which of those approaches makes sense, and how people end up in these different buckets. And I think we can think about really two types of disagreements. We can think about disagreements about sort of people's underlying core values, basically, what do they think is right and wrong? But then some of the healthcare policy debate, and I think that's a little bit true here in the coverage policy debate, but even more true when we get to healthcare spending later, is about what are called sort of empirical disagreements. They're disagreements about how the world actually works that, at least in principle, can be resolved using evidence. So there are disagreements about, if I implement policy X, will it have consequence Y or will it have consequence Z? And in practice, those also shape how people think that the healthcare system should change. So I want to go through each of these in a little bit more detail. So, one big one is there are just fundamental disagreements about what the role of government is. On the left, there tends to be a view that government intervention in the healthcare system is legitimate if it would, in some sense, make the healthcare system work better. On the other hand, at least among some people on the right, there's a view that government interventions, even ones that may be effective, can represent a sort of unacceptable infringement on individual liberty. So I think that's one deep values disagreement that we're often grappling with. I think another big one is how the burden of healthcare costs should be shared across different people. So should people who are sick and need more healthcare pay more for their healthcare, or should we all pay the same amount for healthcare regardless of what our health status might be? Should people at all income levels be expected to pay the full cost of their healthcare, or should the government pick up some of the costs for lower income people and finance that with tax dollars from higher income people? Is that a legitimate thing to do, or is asking taxpayers to pay for other people's health care an improper thing for the government? Then there are all these empirical questions, and there are lots and lots and lots of empirical questions in healthcare policy and in coverage policy in particular, but I think there are three big ones that I want to focus on that I think drive a lot of the debate. The first is, how much does giving someone health insurance coverage actually improve their health? It may seem like common sense that having health insurance makes it easier to get health care and thereby makes people healthier. But at least until fairly recently, hard evidence that demonstrated that was actually remarkably hard to come by. I think the best research on this question, at least in my view, now says the answer is yes. But there are still big debates about just how much health insurance how much healthier having health insurance makes people in practice. There's then another question about the value of having private health insurers in our healthcare system. So the United States currently primarily delivers health insurance through private health insurance companies. That's true universally in the employer market and in the individual market, but it's actually true even in many cases in Medicare and Medicaid, where the government often subcontracts with a private insurer to deliver health benefits through those programs. So some people argue that private insurers are better at ferreting out wasteful healthcare spending, while other people argue that they actually add little value or are actively harmful because they discourage valuable care, or they add on administrative costs or profits into our overall healthcare spending. So a third debate, I think, is about what types of changes are politically feasible. Many reform proposals would change people's existing coverage and change what at least some people owe in taxes. And I think there's a lot of disagreement among people in different who support different types of proposals about what types of changes the public will actually support in practice. So if those are the big questions, where might you come out in terms of concrete policy proposals, depending on how you answered them? So I'm going to go through a table here. I'm going to look at 3 different policy proposals. And for each of them, I'm going to go through, a different set of answers to the 5 questions I just outlined, and then talk about the sort of types of proposals that leads you towards. So, so to start off, suppose you're someone who is comfortable with government intervention, at least in principle, and you think that the burden of healthcare costs should be shared fairly equally between healthier and sicker people. And you think that the government should have a role in making sure healthcare is affordable, particularly for people at the bottom of the income distribution, that using taxpayer dollars to subsidize coverage for lower income people is a reasonable thing to do. You think that insurance coverage is valuable, it improves health and has other benefits for people, but you're not sure how large, what types of changes are politically feasible. You think incremental changes to the healthcare system are probably all the political system can grapple with. So if you have that set of views, many people of that set of views end up proposing things that I'm going to call filling the gaps in the ACA. This is sort of broadly the type of proposal that, for example, President-elect Biden put forward. So to talk about concretely what that would mean, I want to go back to the graph we were looking at before, this sort of map of the healthcare system. Some of what proposals like this would be to try to make coverage more robust or more affordable for people who already have it. So for example, they might change the regulations that affect what providers can charge and what coverage insurers have to offer when people get out-of-network care. Or they might increase the subsidies available to people who are buying coverage on the individual market today so that people in that market pay lower monthly premiums. But another big chunk of this policy agenda is often focused on this 12% of people at the bottom of that under 65 category who are currently uninsured and trying to get them into some form of health coverage. The approaches vary, but often there are sort of 4 big types of things that policymakers who are sort of operating within this broad approach propose. One is, I mentioned before that the ACA allowed states to cover